All right, good afternoon. My name is Rob Chatburn. I'm the research manager at the Cleveland Clinic and professor of medicine at the Lerner College of Medicine. These are my disclosures, and you will have access to the slides and the video recording after I'm done. There's going to be a lot of information in this, and so if you feel overwhelmed, don't be too concerned because you can go back and review it. Just a disclaimer, I don't endorse any particular ventilator or ventilator manufacturer or any particular mode of ventilation. All opinions that you're going to hear me express are mine and do not necessarily reflect those of the Cleveland Clinic. All right, in this lecture, we will start with a review of the mode taxonomy. And if you were around for my previous lecture, you know what I'm talking about. But if you're new, we'll go over some of that. This will lead to the use of the taxonomy to identify modes simply by examining the ventilator waveforms. Next, we define the different types of patient-ventilator interactions and synchrony problems. And finally, we will practice a standardized 4-step procedure for interpreting waveforms at the bedside. You would no doubt agree that if you want to read ECG waveforms, you must first know something about the underlying cardiac physiology. In the same way, if you want to read ventilator waveforms, you need to understand the underlying physics of patient-ventilator interactions. What we will discuss today is based on 3 important papers. The first describes the taxonomy or classification system for modes of mechanical ventilation. The second, expanding on the first, explains what we call goal-directed mechanical ventilation based on the 3 goals of safety, comfort, and liberation. Finally, we will introduce a taxonomy for classifying synchrony problems. First, we define a mode of ventilation as a predetermined pattern of patient-ventilator interaction. A mode is classified using 3 basic characteristics: the control variable, the breath sequence, and the targeting scheme. The mode classification can then be abbreviated using a simple tag. So the control variables are pressure or volume, the breath sequences are CMV versus IMV, and the targeting schemes, of which there are 7, we'll talk about. All of this can be abbreviated with some letters representing the generic name of the mode. Now, all modes can be placed into one of 2 groups, according to the control variable, and this can be either pressure or volume. The concept of a control variable is derived from the basic mechanical properties of the respiratory system. Elastance is defined as the ratio of the pressure change to volume change. Resistance is defined as the ratio of pressure change to flow change. Elastance and resistance are related to airway pressure using the equation of motion for the respiratory system. Pressure control modes allow the operator to preset inspiratory pressure to a constant value, or perhaps to make it proportional to the patient's inspiratory effort, like in modes such as NAVA and PAV. Now again, using the equation of motion, volume control means that the operator presets both the tidal volume and the inspiratory flow. If you can only set one of these things, it's not volume control, despite what ventilator manufacturers tell you. It's a form of pressure control. Now, these are the idealized waveforms you must memorize to be able to recognize volume control and pressure control. With volume control using a constant inspiratory flow, pressure and volume rise linearly. For pressure control, with a constant inspiratory pressure target, flow decreases and volume increases exponentially. The next characteristic of a mode classification is the breath sequence. We see here that there are 3 patterns: CMV, IMV, and CSV. Let's see what that means. We begin with the key definitions of spontaneous and mandatory breaths. Note that these definitions are not what ventilator manufacturers would have you believe. A spontaneous breath is defined as one for which inspiration is both triggered and cycled by the patient, thereby retaining control over the timing of the breath. In contrast, a mandatory breath is one for which inspiration is either triggered or cycled, or both, by the machine. And there are 3 different ways that this can happen. Because the machine is getting involved in triggering and cycling, the patient loses some control over the timing. With 2 types of breaths, we have 3 possible sequences or breathing patterns. The first is CMV, where all breaths are mandatory. The second is IMV, where spontaneous breaths may occur between mandatory breaths. And that definition is important. Third is CSV, where all breaths are spontaneous. Now, they never taught you this in school, but there are 4 very different types of IMV. The first is the traditional form, where the mandatory breaths are delivered at a set rate regardless of what the patient does. IMV2 will allow the patient to suppress mandatory breaths if the spontaneous breath rate is greater than the set rate. And that's important because mandatory breaths cause more dyssynchrony than spontaneous breaths do. IMV3 will also suppress mandatory breaths, but only if the spontaneous minute ventilation is larger. Finally, IMV4 allows the patient to turn individual mandatory breaths into spontaneous breaths if the inspiratory effort is large enough. You'll need to think about this a bit and read the article represented by the QR code. The last mode characteristic is the targeting scheme. And this is basically the software program that creates the unique features of the mode. Currently, there are 7 of these, and we will review them briefly. Set point targeting means that you, as the operator, set all the targets like tidal volume, flow rate, etc. Dual means that the ventilator automatically switches between volume control and pressure control within a breath to maintain various safety limits. Biovariable means that the ventilator automatically changes inspiratory pressure randomly to mimic normal breathing. Servo targeting means that inspiratory pressure is proportional to inspiratory effort, like in the modes NAVA and PAV. Adaptive targeting means that the ventilator adjusts the inspiratory pressure to meet a tidal volume target on average. Optimal means that the ventilator adjusts the target values to minimize the transfer of power from the ventilator to the lungs to minimize the risk of ventilator-induced lung injury. And then finally, intelligent targeting uses the tools of artificial intelligence to automatically manage targets, like rule-based expert systems and mathematical models and more artificial neural networks. Dual targeting is a particular interest because it may be the default mode in some ventilators when you select volume control, and this might not be obvious to you. This graphic shows that if the patient makes no inspiratory effort, then inspiration is volume controlled as expected. If the patient makes a small inspiratory effort, the ventilator senses the drop in inspiratory pressure and gives more flow than you have set. This also shortens the inspiratory time. If the patient triggers the breath and makes a large inspiratory effort, then the breath switches from volume control mandatory to pressure support spontaneous, which is flow cycle. That means that you have converted, or the patient has converted a scheduled volume control mandatory breath into a pressure control spontaneous breath. Hence, the mode is termed CMV. The mode has turned from CMV into IMV, just because you can have these spontaneous breaths that appear between mandatory breaths, and that's why we define it that way. Okay, so how do we use this mode taxonomy? Well, the proliferation of brand names for modes has exploded over the last 10 years. There are now hundreds of unique brand names that represent only a few dozen unique modes by generic classification. To deal with this, we have developed a free phone app called Ventilator Mode Map, and I encourage you to try it. You can get this either for iPhone or Android. Just type in Ventilator Mode Map in a search. You'll see an icon that looks like that. Download that, and off you go. Now, there's a database that runs this phone map, and the way it works is shown in these tables. For example, the table on the left shows that this ventilator has a brand name mode called AC Volume Control Plus. But by looking at its generic tag, you see that it's not volume control at all. It's pressure control with adaptive targeting. Now, if you wanted to get the same mode in a different ventilator that doesn't have that brand name, you just look up the tag, PCCMVA, look to the left, and you see on this ventilator, it's called pressure regulated volume control. And this way you can be assured that these two modes are the same, just where you can be assured that two drugs are the same if they have the same generic name. We have also used the taxonomy for ventilator order screen in Epic, our patient medical record, so that it is similar to the way drugs are ordered. Now, let's move into basic waveform interpretation. Waveform interpretation, like ECG interpretation, depends on your memorization of idealized waveforms that represent basic modes. Here are the pressure, flow, and volume waveforms for volume control with a square constant flow waveform. The green shaded area shows the pressure due to resistance. The blue shaded area shows the pressure due to elastance. And these pressures just fall out of the equation of motion. Here we show volume control with a square flow waveform compared to volume control with the descending ramp waveform. And you can see it has a much different pressure profile, which sometimes can be confused with pressure control. But this is what pressure control looks like with a classical square pressure waveform. Now you need to memorize these waveforms. You need to be able to draw them on a napkin if somebody ever asks you. We will now review the four-step standardized approach to waveform interpretation. The first step is to identify the mode just by looking at the waveform. In other words, you could walk up to any patient's ventilator, look at the waveforms, and be able to identify which of these generic modes they are. Now, how do you do that? Let's try a little exercise. In this top diagram, which by the way comes from not from a ventilator, but from a breathing simulator, we see waveforms where pressure is in green, flow is in black, volume is in blue, and PMUS, or inspiratory effort, is in red. With no effort at the top, we see that pressure is constant, flow is exponential as expected. But below, with inspiratory effort, we see that the target pressure is unchanged. However, flow and volume are increased due to the effects of the force of the PMUS. Every breath has the same duration, we notice, so therefore they must be time cycled. And therefore, every breath must be mandatory, because if the ventilator gets involved with triggering or cycling, then we know that that is a mandatory breath. So what would you call this? Well, the answer is that it's pressure control, continuous mandatory ventilation with set point targeting. An example of a brand name would be so-called pressure control. On many ventilators, they use different names, but that's just one. Here's another exercise. Here we see the same waveforms as before in the top when there's no inspiratory effort. But there's a difference. When the patient makes an inspiratory effort on the bottom, then, unlike before, the inspiratory pressure target goes down, but the tidal volume stays the same. Furthermore, the inspiratory time is decreased, meaning that the breaths are both patient-triggered and patient-cycled. Hence, we have the possibility of both mandatory breaths, the patient doesn't do anything, and spontaneous breaths that the patient makes inspiratory efforts. Furthermore, when there are spontaneous breaths, the mandatory breaths are suppressed. Now, knowing all of these facts, you should be able to deduce what the mode tag is. Well, what do you think it is? Well, in this case, it's pressure control, IMV type 2. Type 2 because the spontaneous breaths suppress the mandatory breaths. And now you see the importance of knowing that there are different kinds of IMV. The spontaneous or the mandatory breaths, the first A, are controlled adaptively, and so are the spontaneous breaths. The second A. In fact, when the spontaneous breaths suppress the mandatory breaths, this ventilator acts like volume support. The patient doesn't make any effort. It acts like pressure regulated volume control. And this is a mode called auto mode, and of which there are 3 different types. This particular one, as I said, is PRVC, switching to volume support depending on the patient's spontaneous breath activity. Now, the rule of thumb in the reading waveforms is this. In volume control, look for load effects on the pressure waveform. In pressure control, look for load effects on the flow and volume waveforms. This is step 2, defining the load. So again, based on the equation of motion, in volume control, we're controlling the right-hand side of the equation. So any changes in mechanics will be represented by changes or deformations in the pressure waveform. In contrast, volume or pressure control means we're controlling the left-hand side of the equation. It can't change. So if there's anything happening on the left-hand side, effort, or if there's any changes in the mechanics, then we look for load effects on the flow and volume waveforms, like that. Now, as I said, step 2 is to identify the load. And if elastance is increased, we say that there is an increased elastic load here. E times V has units of pressure. So that's a load. We call that the elastic load. If resistance is increased, again, resistance times flow is a pressure, and we call that the resistive load. And if there is pressure or flow waveforms are distorted by inspiratory effort, or PMUS, we say there is a PMUS load. This figure shows the effects on the waveforms of increased elastic load in volume control with a constant inspiratory flow. This figure shows the effects of increased resistive load. Now, this figure shows the effects on the waveforms of increased elastic load in volume control with a ramp flow. And you can see that the pressure waveform looks much differently, but it is still partitioned into an elastic load and a resistive load. This figure shows the increased resistive load effects on the waveform. The ramp flow is unique in that without the very first pressure that you see here is all due to resistance, because there's no volume accumulated. So this is just the elastic load, the resistive load. And at the end of inspiration, if flow hits 0, then the only load left is the elastic load. So without doing an inspiratory hold, you can separate out the effects of resistance and elastance just by looking at the waveform. So that's why here, when the elastic load is high, you have a high end inspiratory pressure. Here, the resistive load is high, so you have a high initial pressure and a low final pressure. So that's just a little trick and an advantage of using ramp flow. This figure shows the effects on the waveforms of increased elastic load in pressure control, basically a lower peak flow and a lower tidal volume. And this figure shows increased resistive load. Again, it has effects on tidal volume and flow. In volume control, PMUS load deforms the pressure waveform like this. If it's scooped out a little bit, that's not a big deal. If the scooping goes below baseline pressure, that's severe and needs to be addressed. Here's examples. Here's a comparison of volume controlled breaths with no inspiratory effort on the left, a mild effort leading to work shifting in the middle, and severe work shifting, sometimes called flow starvation, where the airway pressure actually drops below the baseline pressure. That's something that needs to be addressed clinically. What happens in pressure control? Well, the effect of PMUS is to distort the volume and flow waveform. the higher the PMUS, the higher the tidal volume in the flow. In pressure control, the same conditions distort the flow waveforms and increase the tidal volume. So again, on the left, there's a passive patient. And in the middle, there's mild work shifting with the increased flow and tidal volume. And onto the right, here we're seeing extreme work shifting. And in this case, not flow starvation, but rather an excessively high tidal volume, which might be dangerous to the patient. Now, another key concept when we're looking at waveforms is this idea of a time constant. The time constant is a mathematical construct. It's calculated by multiplying resistance times compliance, and what you get are units of time, usually in seconds. And what the time constant tells us is the amount of time it takes for an exponential curve change by 63%. So for example, the control volume will rise 63% in a time equal to 1 time constant. It takes 3 to 5 time constants to get complete equilibrium of inspiratory volume. In contrast, the same way on expiration, and this is true of any mode of ventilation, passive exhalation proceeds as an exponential curve, and it takes 3 to 5 time constants for the patient to completely exhale. And if your expiratory time isn't set that long, then you're going to get some degree of gas trapping and autopee. So that's how the idea of time constants can come into play. So again, basically, if you have a short time constant that generally is due to a low compliance, a stiff lung, as if you have a long time constant, it takes a long time to exhale, that's generally due to a high distance. And that again is a concept that we can apply to our waveform interpretation to know what's going on with the patient. In other words, to find out if the load is an elastic load or a resistive load. So here again is a complete set of waveforms. This is in pressure control mode. As you can see from the top waveform, it's pressure. The middle waveform is volume, and the bottom waveform is flow. On the first, in the normal patient, you see a nice expiratory curve, exponential curve going down and going all the way to zero flow. In the middle, we have a high resistance. High resistance gives you a long time constant, and you can see there's still flow at the end of the expiratory time. So there's going to be some gas trapping. In a situation with a low compliance, now we have a short time constant, and so the flow returns to zero very quickly. So these bottom waveforms here, looking at the shape of these curves and describing it in terms of the time constant, is a very practical way to describe what's going on with the patient. So again, just in summary, this black curve would represent a normal expiratory flow. The blue curve represents a short time constant. The green curve represents a long time constant. And the red curve represents a distorted waveform due to expiratory effort on the part of the patient, PMUS. Again, decreased compliance, short time constant, decreased resistance is a long time constant, and increased expiratory flow means PMUS. Okay, let's do some exercises. We have some time for that. So now I'm giving you 4 waveforms, A, B, C, and D. And I'm going to ask you which of the following is most consistent with an increased resistance. What do you think? I'll give you a second to think about it. I'll give you the hint. Look at the flow waveforms and the time constants. Well, the answer is D. How do we know that? Well, we have a low peak expiratory flow in D. Peak expiratory flow is just the set pressure, inspiratory pressure divided by resistance. So if resistance goes up and the pressure difference doesn't, I mean, the delta P that you have set, the inspiratory pressure you have set doesn't change, then as R goes up, flow must go down. There's a long time constant, which is indicated by taking a long time for flow to decay back to zero compared to the other flow waveforms. Okay, let's try that again. Here we have A, B, C, and D, where A and C are pressure control modes, whereas B and D are volume control breaths. And which of these scenarios, A, B, C, or D, which of these breaths is most consistent with a decreased compliance or a hint, short time constant? What do you think? Well, when you get familiar with this, you'll see it almost instantly. It'll only take you a few seconds. The answer is B. Why? Because we have a short time constant. How do we know it's short? Because it returns the flow very quickly. We also have an increased slope on the pressure waveform. And it turns out the slope, the change in the rise over the change in the run, is proportional to elastance. So a high slope is a high elastance. High elastance means low compliance. Now, here's another way of thinking about patient-ventilator interactions, and this is step 3. And in step 3, what we do is we divide the breath into phases. The red or the green area is the trigger phase. The yellow area is the inspiratory phase. The red area is the cycle phase, and the dark black area is the expiratory phase. And in each of these phases, we're going to get a specific type of discordance or patient ventilator synchrony problem. We have described this in great detail in a paper that you see here, and we have named these specific discordances as early trigger, late trigger, failed trigger, false trigger, work shifting, early cycle, late cycle, and expiratory work. We're going to go into these in a little bit more detail. Now, the key concept here is the patient is always the reference, right? What the patient demands is the gold standard, and what the ventilator does is try to catch up, basically. So if there's any difference between what the patient wants and what the ventilator gives, that leads to some type of discordance. Here, we see that patient signal can be represented by the EDI signal, let's say from a NAVA catheter, or it could be referenced by esophageal pressure catheter. And this airway pressure is what the ventilator is trying to do to catch up with the patient signal. So in 1, we see the start of the patient effort. In 2, what we see is the beginning of the trigger phase. In 4, we see that the patient is nearing the end of the peak effort. 5 represents the end of the patient's respiratory effort and beginning to relax. And 6 is the actual cycling off of the ventilator. So you can see trigger of the ventilator, the event of the ventilator triggering is well after the patient makes an effort. Same thing with cycling. Cycling occurs after the patient has stopped making an inspiratory effort. Now, depending on the type of breath that we're delivering, if it's a mandatory or spontaneous breath, these delays in triggering and cycle may or may not be clinically important, and we'll get into that. So step 3 then is to define the patient interaction for the trigger phase. Now, normal triggering would be something like this. And again, these are ventilator pressure and flow waveforms, and we have drawn in an imaginary PMUS signal. So we see that the PMUS starts here, and very shortly after that, the ventilator triggers with a flow trigger signal. On this ventilator, we know it's flow triggered because the flow waveform is colored white. If this had been a pressure trigger, then this waveform would have been colored white. So this is the normal delay, and we can live with that. We can't get rid of delay on any mechanical ventilator. We can just minimize it to the point where the patient doesn't even notice. This, however, is what we call the late trigger. So the patient's effort starts here, and the ventilator doesn't trigger until way over here. The pressure drops way down. This is pressure triggering, And that's probably too much of a delay. You could probably fix that just by changing the sensitivity. Here is what we call an early trigger. Why is it an early trigger? Well, because we see the patient trigger effort doesn't happen till after the ventilator is triggered. So in other words, the ventilator has a time-triggered breath way back here, and that somehow stimulates the patient to make a trigger effort. In the literature, that has been called reverse triggering, but we prefer to call it early triggering because there's many causes of this, not just entrainment or anything like that. So you see a deformation in the pressure waveform and more easily on the pressure waveform, on the flow waveform in pressure control mode. So that's early trigger. What do you think's going on here? Well, we see a whole bunch of breaths all stacked together with no time to exhale. What is going on here? Well, this is a false triggering, probably due to a large leak. False meaning that the patient didn't do it. You can't do it because PMUS is 0. In this case, the patient isn't making any effort whatsoever. Here, we see what's called a failed trigger, one of the most common and perhaps most important synchrony problems. What we see is a normal passive inspiration, and then during the expiratory time, the patient makes an inspiratory effort, which we see reflected as a positive going flow, but it never makes it to 0. So if the flow doesn't cross 0, the ventilator doesn't even know that the patient's connected. So the patient makes an effort, the effort failed to trigger the next inspiration, so we call that a failed trigger event. So step 3 is to define the patient-ventilator interaction in terms of inspiration. So here we have normal work shifting and severe work shifting. Well, what do we mean by work shifting? Well, if you take a plot where we put the work of breathing or the work of inspiration on the vertical axis that the ventilator does versus the work that the patient does by PMUS, then we get some interesting patterns. In volume control or volume guarantee modes or pressure control with adaptive targeting, if the patient makes no effort, then the ventilator does all of the work of inspiration. But as the patient makes more and more of an effort, as PMUS goes higher and higher, then the work that the ventilator does goes down. Because in volume control, the total amount of work is fixed. So if the patient does more, the ventilator has to do less, as we saw earlier at the equation of motion. So that's an example of work shifting. If it gets to be too severe, it's not a good thing. Well, what happens in pressure control? Well, you know that in pressure control, no matter what the patient does in terms of inspiratory effort, the airway pressure stays the same. All the thing that happens is that the patient gets a larger tidal volume. So what that means is the work per breath stays the same. The total work goes up because the total volume goes up, and work is a function of pressure and volume, those two working together. So the total work goes up, but the work that the patient does relative to the total work stays pretty much the same. And so that's not quite as bad as in volume control with work shifting. But is there any way around this problem? Yes, indeed. And that is modes like ANAVA and PAV that have proportional assist. Why is it called proportional? Well, because the more work that the patient does, the more work the ventilator does. And that maintains a balance of work and decreases the discordance between the ventilator and the patient. Here we see an example of work shifting in volume control. On the first breath, the patient makes a small inspiratory effort halfway through inspiration. We would also call that early triggering, but it's not a big deal. And this area here between what it would have been and what it is, this area right here, is the work that the patient's doing. But this area here that's left is all the work that the ventilator is doing. And still, the ventilator is doing more than half the work for the breath, so that's not a big deal. In fact, we might want to even encourage that so that the diaphragm remains healthy. Over here, however, we see that the patient is making such a high inspiratory effort that the airway pressure drops below baseline. That's called severe work shifting or flow starvation. It's called starvation because the ventilator doesn't provide as much flow as the patient wants. Over here, it's not flow starvation because the the ventilator is always providing more flow than the patient wants. And that, you know that because the pressure is always above baseline. So there again, that's normal work shifting, and this is severe work shifting. Severe work shifting means you have to clinically assess the patient, figure out why they're making this huge inspiratory effort, and fix it. And if you can't fix it, then sometimes you have to paralyze the patient to avoid damage to the diaphragm or causing pulmonary edema. So now here we have pressure shifting and pressure control. I mean, work shifting and pressure control. Completely different situation here, right? So at the first breath, we see a patient trigger effort only, a very small effort, and the patient relaxes, and you get a normal exponential decay in the flow waveform. Over here, the patient is making a normal inspiratory effort. They are causing increased flow and increased tidal volume, but so long as the tidal volume doesn't go above a normal or safe dosage of, say, 8 mLs per kilogram, then you're not going to be too worried about that. Over here, however, you get severe work shifting. You see a deformation in the pressure waveform. You can't call this flow starvation because the pressure doesn't go below baseline, and the patient gets whatever flow they want because that is what pressure control does. But it's severe in the sense that you probably have an excessive tidal volume dosage, higher than 8 mLs per kilogram. And again, this is something you have to assess clinically and do something about. Here is work shifting in adaptive pressure control, or in a mode like pressure regulated volume control, or volume support. As the patient increases effort, the tidal volumes get larger and larger, but the ventilator has adaptive targeting. It responds by decreasing the inspiratory pressure. So the tidal volume stays relatively constant. However, the patient is doing more and more of the work. So that's a clinically different situation than work shifting and volume control, but still something that needs to be monitored. So the next step in the next phase of step three is to define the patient interaction for the cycle phase. So here we have what we'd probably consider to be normal synchrony. The patient makes a small effort, then just relaxes, and he gets a normal time cycle breath. I suppose if you were going to be strict about this, you would say, well, the patient stopped making an effort here, and so the cycling didn't happen till way over here, so we would call that late cycling. But it just depends on how you look at it, how formal you want to be about it. Late cycling, real late cycling, looks something like this. Here we see that the patient makes a larger effort and then relaxes. At this point, their effort begins to go away right about here. And on this particular ventilator, the patient isn't allowed to exhale until the expiratory time is finished. And so you get this little sort of inadvertent inspiratory hold, and that's your hint that this is a late cycling phenomenon. So you see patient effort indicated by the distortion of the flow waveform. Patient relaxes, can't exhale, so you're stuck right here until the ventilator cycles off. Late cycling. On the other hand, if you have a mandatory breath, let's say, where you have a preset inspiratory time, but now the patient's neural inspiratory time, or the duration of the effort, is much longer than the preset inspiratory time, then the effort spills over into the expiratory time, in the expiratory phase. How do you know that? Well, classically, you clip off this normally peaked expiratory flow. So the patient's trying to inhale, the ventilator is trying to exhale, and you get virtually no flow at the very first part of exhalation until the patient relaxes, and then you get a normal expiratory curve. So this is a situation where the neural inspiratory time is longer and not shorter than the preset inspiratory time. And the way you fix that is how? What do you think you would do? Well, you just lengthen the inspiratory time. Or you allow the patient to cycle off by themselves and not have a mandatory breath here, just have a spontaneous breath. Now we look at expiration, finally in step 3. Is it a normal passive exhalation, or do we see some evidence of expiratory work? Well, here on the left, we see a passive normal exhalation, no problems. We get a curve that is exponential. On the right, we see expiratory effort by the patient. Expiratory effort causes expiratory flow, so you get more expiratory flow than you would see under passive conditions. This shows that the patient is doing work. They're huffing and puffing, probably during inspiration as well. And that's the situation you probably want to address clinically. Okay, you know the theory. Let's try some exercises. What's this? Take a close look at it. Doesn't look good, does it? What do you think is going on here? Well, what we start off with is, what is the tag? In other words, what is the mode of ventilation for this patient? We're going to call it volume control, CMVS. How do we know that? Well, because we have a constant inspiratory flow. The only way you're going to get a constant inspiratory flow is because if you set it. So if you set flow and tidal volume, then you're going to get volume control. Also, every inspiratory time is the same length. So that's, these are all mandatory breaths. And we don't see any compensation by the ventilator by the inspiratory effort as indicated by the distortion of the pressure waveform. And so we're going to call that set point targeting. Also, the fact that the pressure waveform is distorted by inspiratory effort and not the volume and flow waveforms, again, proves that this is volume control. Again, this comes from the equation of motion. So what is the load here? Is this load elastic? Is it resistive? Or is it PMUS? What do you think? Well, it should be pretty obvious that this is PMUS, this distortion, this pulling down of the pressure way below the baseline pressure. This is baseline pressure. This is inspiratory pressure. We would call this severe work shifting, right? So what about the trigger? Well, that seems fairly normal. It happens pretty quickly. This is a pressure trigger, as you can see. Inspiration, again, severe work shifting. Pressure is dropping way down, severely distorted. The cycle is normal because the patient is relaxing right about the time that the ventilator shuts off. And just by chance, somebody has set the inspiratory time to be about equal to the patient's neural inspiratory time. So we're going to say there's no problem there. And the patient relaxes during exhalation. There's no distortion of the flow waveform. And in fact, it's a pretty normal time constant. So there's probably no resistive or elastic load involved there. So what intervention would you do here? What would you recommend? How about sedation and paralysis if you couldn't address the reason why this patient was doing this? Or maybe they just need to be extubated. It all depends on your clinical assessment of the patient at the time. Here's another exercise. We begin with what's the tag? Look at the pressure, volume, and flow waveforms and ask yourself, is this pressure control or volume control? Well, because we have a constant inspiratory pressure and we have an exponential flow and volume waveforms, we know that this is pressure control. Also, we see that every inspiratory time is the same. And it looks like it's being time cycled. So these are all mandatory breaths, at least as far as we can tell. And there's no indication that the ventilator is doing anything automatic. So we're going to call that set point targeting. So what's the load here? What do you think? Is it PMUS? Is it elastic? Or is it resistive? Well, how do you tell? The easiest way to tell is to look at the flow waveform. And we see that it takes a long time for the flow to come back to zero. And in fact, it doesn't go all the way to zero, right? So that should also indicate some gas trapping is going on. So that's a resistive load, a long time constant, high resistance. So what's the patient-ventilator interaction? How are we going to classify this? What type of synchrony problem are you seeing here? It should be very obvious. It happens all the time once you recognize it. Well, we have possibly a failed trigger over here, but more obviously we see it right here. This distortion in the expiratory flow curve is PMUS. Patient makes an inspiratory effort, flow does not go through zero, ventilator doesn't know that anything's going on, so it's a failed trigger effort. Inspiration is normal. Patient doesn't do anything. Over here on this breath, however, look at this. The flow waveform is distorted at mid-inspiration. So this is PMUS as well. So in this situation, we have two trigger problems. We have a failed trigger and we have an early trigger. Again, it's early because the machine triggers here and the patient makes an inspiratory trigger effort here. The machine is before the patient, it's early triggered. Other than that, inspiration is normal. The cycle appears to be normal. We have a nice peak expiratory flow. We have no inspiratory hold here. Everything looks good. Expiration is normal and passive, except for these failed trigger efforts. So what intervention would you do here? What do you think you would do to fix this? Again, it happens all the time. Well, one thing you could do is reduce the rate so the patient has a chance to trigger. Reducing the rate allows the patient to exhale more fully and has less autopeep. Less autopeep, the less chance of a failed trigger effort, right? Because autopeep causes failed triggers. That's what I would do. Okay, here's another exercise. What do you think about this? Well, start with the tag. Again, it appears to be pressure control. Every breath seems to be mandatory, and there's nothing automatic happening, so we'll call that set point targeting. What's the load? Well, not much is going on during inspiration. Not much is going on during expiration. Although, this looks kind of funny, right? So we could say it's probably normal lung mechanics, but we do see a patient-ventilator interaction problem. We see a synchrony problem. What would that be? What happens when you see this clipping over here? Well, we have a normal trigger on the trigger phase. We have a normal inspiration because we don't see much distortion of the flow waveform. However, the cycling is early. The patient is making somewhat of an inspiratory effort because it's not a perfect exponential curve here. And the patient's inspiratory effort is bleeding into the expiratory phase, so you get this clipping of the peak flow. So we would call that early cycling. So in other words, the preset inspiratory time is shorter than the patient's neural inspiratory time. But beyond that, we have normal passive exhalation. What would you do with this? How would you fix it? Well, you simply increase the inspiratory time. If the patient's neural time is from here to here, well, then just set the inspiratory time on the ventilator from here to here. And that should go away, and the patient should be more comfortable. Here's another exercise. What's the tag? Well, by now you should see this is pressure control CMV. And I know we're hitting on pressure control. It's just because it's easier to see a lot of these things. What's the load? Well, we look at the flow waveform in pressure control. We look at the flow waveform and we see that's distorted. It's not a nice exponential curve. So it's a PMUS inspiratory effort. What's the patient-ventilator interaction? Well, the trigger is normal. Not too much of a delay there. It's a pressure trigger. Inspiration. We have a little bit of work shifting because, again, this is billowed out. It's not a nice concave expiratory curve here, or exponential curve. Cycling is late. How do you know the cycling is late? Well, the patient is making an effort here. They stop making an effort here. When they relax, the pressure rises a little bit on the airway pressure because the ventilator can't catch up in time. It just rises to the preset pressure target. It doesn't let the patient exhale on this particular ventilator. And so the patient has to hold out here and then is allowed to exhale. That means the cycling is late. The inspiratory time is longer than the neural inspiratory time. Expiration is normally and passive. What are you going to do about that? How do you fix it? Well, you should say decrease the inspiratory time. Make it closer to the patient's neural inspiratory time, or just let the patient cycle. Put them on something like pressure support or volume support. Okay, I want to point out some other resources for you in learning how to do this. Every other Tuesday from 2 to 3 p.m. Eastern time, we conduct what we call Vent Rounds. Vent Rounds is a live online presentation of ventilator waveforms, real ventilator waveforms from real patients. We annotate them. We go you through the 4-step process to define what's going on and what you're going to do about it. And it's just a lot of fun, and you can submit your own waveforms if you want. So I recommend that you join us for that. As I have mentioned before, you can also take Save a Basic, Save a Theory, and Save a Lab online for free. Again, you can use this QR code and learn all this stuff on your own time and at your own pace. And so with that, I'm going to end and ask for any questions and share with you this funny cartoon that somebody sent me. Believe it or not, they took a photograph of my face and they mixed it with a cartoon of Superman, but they put a T on there for taxonomy, man. I thought that was kind of cute. So with that, I am going to stop sharing and ask if there are any questions from the audience.